Well, we have improving adherence to eye examinations in youth with diabetes.
Okay, I just go past. Okay.
Yeah.
I don't want to steal their thunder. Everybody close your eyes. Okay, great. All right. Well, I'm Allison Smego. I'm at University of Utah and Intermountain Health in Salt Lake City, and happy to present to you guys on how we've improved our retinal screening. Okay. Just a weird picture here. Okay, so just to give you a little background on our hospital and our clinic. So we're located in Salt Lake. Is this a pointer? Okay, cool. Which is kind of like right there, that like slightly blue one. And we have a number of different outreach locations. All of these little bubbles with the IH are Intermountain facilities, but they're not all ones that we currently go to. So we cover a lot of the state. We have a second primary location, which is about 40 minutes south of us in Lehigh. And then we also have 3 other outreach locations as well. We have, as you can see, a large catchment area from multiple states. And uniquely, we have about 75% of our patients are on private insurance and only about a quarter are on public insurance, which I know is different from a lot of centers here. We have about 2,500 and growing patients with type 1 diabetes, with about 400 new diagnoses a year, and then 300 and growing patients with type 2 diabetes. So, preaching to the choir, but diabetic retinopathy is one of the leading causes of blindness in adults. And regular screening allows for timely detection and intervention to ultimately reduce the risk of vision loss in these patients long term. Our clinic historically really struggled to get these retinal exams done and to get the records sent to us. And so we had a big unknown for these patients, and we really wanted to prioritize improving this for our population. So that leads me to our goals. So our aim was to increase retinal exams among patients with diabetes in alignment with the ADA screening recommendations. And we started this in early 2024. And so our goal was to improve this by December of 2024 initially. So for our patients with type 1 diabetes, we aim to go from 75 to 82%. A weird number, but yes, we aimed for 82%. And then with type 2 diabetes, from 50 to 55%. And notably, this pilot was in our main Salt Lake location for starters. So a couple of the key drivers that we identified as barriers to why the eye exams weren't getting done. If patients were having them done, we were not consistently getting the documentation sent to us. Since patients are coming from such a large area, they were going all over the place as far as where they were getting these eye exams done. And then if they were getting sent to us, they were sometimes getting scanned into the medical records, sometimes showing up in like our folders, sometimes just disappearing as things often do. And then we also had providers that were maybe not as up to date or weren't as bought in on the ADA recommendations as far as screening. And so we really focused on educating and providing resources for those providers. And then also just the burden of having another office visit is quite significant for a lot of families. And so going to another location, taking off work or school and paying for the travel there was burdensome. So our initial interventions were really focused on documenting the retinal exam, so documenting this being done. We changed the way our intake forms occurred, and so our MAs were asking at every visit if the patients had had a recent eye exam, and then documenting that. So we had this, this is a Cerner, this is from our Cerner EMR, for those that are familiar. So we started utilizing this diabetes eye exam form that we could enter in when it was done. And if you notice, it allows you to note whether it was scanned into the EMR or not, and then you can change the date. And then we helped all the MAs and providers set up filters so you could easily go in and see when their last eye exam was done instead of having to scroll through the endless number of documentations that are in the EMR. And then we ultimately got a RetinaView camera. So we were fortunate enough to have support of the institution to buy a camera and start doing the retinal screening in our clinic. Again, this was at our main hospital location, and the RetinaView camera there's a picture there, but basically you can take it from clinic to clinic or room to room and take pictures of the kids' eyes after they've been in the dark for about 5 minutes. It's billed through their insurance, typically just through their regular health insurance, because most health insurances allow one eye exam per year. And so it was really well received by patients. This is just a workflow of what this all looked like for our patients and for the staff in clinic. So if they were eligible for the eye exam and were open to doing it, then our MAs would go ahead and do that. The pictures then sent off to ophthalmologists that we contract with, who are actually contracted through the camera. And then we get a read back to our EMR within about 24 hours, sometimes 48, but pretty quickly. So this is our data from our main location. Again, just showing that you can kind of see at the bottom here when we started intervention and when we got that camera in the spring of 2024, you can see that in both patients with type 1 and type 2 diabetes, the percent of patients that got the retinal exam just pretty much exponentially went up for us. And then this is our second clinic location. So this was our second primary location, and we got a RetinaView there in early 2025. So we were able to prove in our first location that it worked so well that we were able to secure funding for another camera. So we do have a camera in our second primary location at this point in time. We don't have them for our other outreach clinics as of now. So just conclusions. So the standardized documentation really improved our ability to identify eligible patients for retinal exams. We involved the entire team, not only providers, but the nurses and medical assistants as well. The in-clinic RetinaView camera was pretty pivotal for us as far as improving our screening rates. We have had no billing complaints thus far, and it's been almost 2 years that we've been using it. It's been really fast turnaround. And for anybody that has abnormalities, we then refer them on to see an ophthalmologist in person. And then, as I mentioned, we were able to secure a second camera for other location. Our new challenge is we have a new EMR as of September. And so we didn't manage to do any eye exams in September because we could not figure out how to get it integrated and how to bill for it. So we are back happily online doing them as of October. But we are still figuring out what the documentation looks like and how to track it over time. And we moved to Epic, yes. So any questions or other comments? Yeah. Oh, so.
You mentioned that the picture gets sent to people you're contracted with through the camera. Do I understand correctly that that's through RetinaView, not through your institution?
Correct. So we did, we looked at different options as far as who would be reading the pictures, and we looked at our ophthalmologist or contracting with people through the camera company. And it was more seamless to go that route. And so we've just contracted with them, and they are the ones that read it.
I'm glad you commented about the billing complaint, because I think a lot of people wonder about that. And this is a weird question, and maybe you might not have an answer, but as someone that sees an eye doctor, I have really funky eyes that have nothing to do with my diabetes, but that also has to, get the screening. Does that come up at all in your patients that you're like, oh, you need vision screening, not just retinopathy?
Yeah. So in our patients that wear glasses, we typically will say, you still need to go see your eye doctor. And so a lot of them opt not to have the vision screening done in our clinic because it would potentially be an additional cost for them.
But that's why you have those questionnaires, so you can still document that they're getting it.
Okay. Yes. So for those that go elsewhere, we can still document that they went in September and all was good. Yeah.
Elizabeth from Johns Hopkins. Just curiously, what percentage of your patients had referable diabetic retinopathy? And were you tracking whether or not they made it to an eye doctor if they were told to go?
Yeah, that's a really good question. A very small percentage. I have had maybe 2 patients that have had any abnormalities, and one was a coloboma. So I don't have great experience with that, and as of now, we are not tracking if they make it, but that's a good point. I think individual providers, it's presumed that the individual provider would sort of make sure that that happens. But as far as documenting that, no, and that's probably something we should look at long term. I will say the only downside of the RetinaView camera is if there is not a big difference from the eye color to like the pupil, it has trouble with that picture. So occasionally we cannot get the picture done in clinic, and it's for people that have like much darker eye colors. Any other question? Okay.
Another kind of billing question. I think when we were thinking about doing it for UCSF, the cost for like it was like a rental cost for the ophthalmologist to read. Is it expensive with it?
So the upfront cost of the camera is not insignificant. It's expensive. And then there's an ongoing cost, like a monthly cost for like upkeep of the camera and for the reads and that contract cost. But if we did, I think it was like if we were able to do about 20 a month, it would pay for itself, that sort of ongoing cost. And we haven't had trouble hitting that at this point. So it's really the upfront cost that ends up being the big kind of lift for a clinic.
Thank you.
Yeah.
Allison, thanks so much. Is it a charge that the patients see, or okay, so
Yeah,
it's sort of an additional increment?
Yeah, it's not lumped into like our clinic fee. It is a separate charge. And so we let patients know that. Okay. All right. Thanks, guys.
Thank you. So I believe we have Nationwide next. I'm gonna have to change the slides back. There you go. There you go.
Thank you. I apologize about, I mixed up the room, so I was in the wrong room. I realized too late. Leena Mamilly from Nationwide Children's. I'm a pediatric endocrinologist, an assistant professor, and I'm going to be talking about our project for increasing urine microalbumin screening compliance in a pediatric or type 2 pediatric type 2 diabetes population. And I want to start by introducing our type 2 program. We have at Nationwide Children's a dedicated type 2 diabetes in youth program that was established in 2014. So before I joined Nationwide Children's by my colleague, Dr. Henry, and then we expanded in 2021 with ability to see more patients. We are a multidisciplinary clinic. We're also multi-specialty. We have a psychologist and a nephrologist on board. And we see patients for 2 sessions a month, and that's 6 patients for each of us. So it ends up being about 24 patients a month. And so you can imagine that this is not, the entire type 2 diabetes population at Nationwide Children's. So the rest of the patients are being seen in other general diabetes clinics, so alongside the type 1 diabetes patients and other types of diabetes. And then our type 2 diabetes patients who are only on metformin or in diabetes remission or going through a bariatric surgery journey, they are seen by our comprehensive weight management program, which is under general pediatrics. And so in order to reduce so from the start, actually, in order to reduce the length of or the duration of the visits, we divided our visits into 2 types, visit A and visit B. So when they see Dr. Henry, they're seeing also a registered dietitian and a social worker. alongside diabetes RN or LPN, who rooms the patient. We have our diabetes nurses and LPNs are actually dedicated for type 2. So the patients are seeing almost always they're seeing the same faces, as they come in. And, we found that to be very helpful. And then visit B, which is my visit, they'll see the diabetes educator and therapeutic rec specialist. And then that's a person who addresses physical activity habits and, physical activity suggestions and this sort of thing. And then we have also a clinical pharmacist who helps us a lot. And so this slide, shows our data, but this is from a couple of years ago. I haven't had the chance to get more recent data. We've grown since, but we take care of a good number of type 2 diabetes patients, 171 unique patients, and that's only under endocrinology, so not encompassing maybe small pockets in other clinics. And our numbers are, demographics are very similar to, what you see in your, academic centers, where average age is 15, and then most of these kids identify as Black or African American, and then 30% are white and 15% Hispanic or Latino, and you can see that most of our patients are Medicaid insured. This is our team, and none of this work would be possible without them. Like I said, our patients see the exact same faces every time. So my colleague, Dr. Henry, myself, and then Dr. Kalash is our nephrologist who staffs our clinic for to see patients who have high blood pressures or microalbuminuria or other situations, related to his specialty. And then we have our RNs and LPNs. On the left-hand side, in the bottom center, we have, this is our type 2 diabetes program coordinator. She's our admin who actually attends our clinics. She orchestrates the flow of the clinic visits so that patients are not sitting in the room, for a long time without seeing somebody. And then she will also help us in the upfront by calling patients and confirming appointments. And that's specifically for our type 2 diabetes program, so the dedicated clinic. And then we have our also quality improvement team. All right, so our metric, diabetes kidney disease, I don't have to, preach to this audience about how important it is to identify and address diabetes kidney disease. One of the most common complications in adults and children with type 2 diabetes. Search showed, shocking numbers of 20% incidence of diabetes kidney disease by 21 years of age. Or I should say prevalence. And then this is also very, very tightly related to cardiovascular complications and mortality in individuals with type 2 diabetes. And so right now, what we are recommended to use is the urine microalbumin creatinine ratio screening at diagnosis, and annually, hopefully we'll have better markers, as we discover them in the future. And this is one of the QI tools that we used is the effort impact grid. So we sat down, we came up with multiple things with the help of Melek, our QI coordinator. And I'm not going to read through this. I'll skip over to our key driver diagram. And so after we met as a team, we identified a few of the key drivers. The key or the project aim was to increase the screening rates of microalbuminuria in youth with type 2 diabetes. We identified the age cutoff as less than 19 years, so 18 years or younger. Our baseline was 74%, and this is actually an improvement since we started the type 2 program. We used to be at the 60% or so. We increased it to 74%, but we wanted to increase it further and hopefully encompass everyone if possible. And so the key drivers that we identified were patient participation. So that's the biggest barrier, is you tell the patient to go to the lab and get the microalbumin done, but it doesn't happen. And then patient appointment adherence. So they have to show up to clinic in order for you to to recommend anything. And then staff practices. So a lot of times those tests were not being ordered. And then care access, which is a much bigger rock to move. All right. So we thought that the lowest hanging fruit was staff practices because, we have a specific team and we could change those habits or, install new habits that are important. So one of the first things that we did is that we met with our team and within a department-wide diabetes kind of CME platform. And we talked about the importance of microalbuminuria screening and the guidelines and, encouraged people to order. And we talked about, what to do with a positive screen and that sort of thing. In the dedicated type 2 diabetes clinic, our clinic coordinator was pre-identifying patients. And one of the things that made it possible for an admin or a PCA, patient care assistant, to do that is that we have a care gaps space in Epic in the patient's chart that identifies a patient as due for that screen. This actually replaced multiple BPAs that we had before that were causing alarm fatigue. And so we replaced that with care gaps and this helped identify those patients. We also enabled nurse ordering through licensed professional initiated protocol. So the nurses are able to place those orders without providers signing them. Oh, and then the signage also is a big thing, is that we posted signs for people to remember to send urine for microalbumin. In terms of patient participation, the intervention was very simple, but it was effective. We collected urine on everybody with type 2 diabetes as they were roomed. We gave them a water bottle to drink and then, go to the bathroom. And we told them that if it's not due, we're not going to send it. So that way we just tossed out the screens that did not need to be sent. And then we created also a mail kit for patients to get the urine done. If we had a follow-up or, they forgot to do it, then we send them this kit with like a sample cup, instructions on how to collect the urine, and then printed the orders to take to their home lab. And this is the bigger side of things, which is appointment adherence. We have a coordinator, fortunately, but she can't work with all diabetes patients. But we do send automated reminders through Nationwide Children's Epic, and then they get phone calls, they get social work help if they can't get to their appointments, and then we partner also with Nationwide Children's Partners for Kids, which is an accountable care organization that's founded by Nationwide Children's for case management and to help patients get to their appointments and coordinate visits and help with that. Our current intervention is discussing FMLA with all parents of children with type 2 diabetes, because one of the biggest barriers is that parents can't bring them in because they think they'll be fired if they miss so many days of work. And so I don't think I have too much time, but I think this is the last slide maybe. But yeah, so I mean, we met as a team. We created this updated KDD in the end of January of this year. And so far we've been seeing really good results. We had someone vet the results just to make sure that, this is not, because it did seem to be a very big improvement. And, we're happy to see this exceeding our goal. So our next step would be to actually focus on other screens and add them onto this project so that we have a screening bundle, if you will, for patients with type 2 diabetes, make sure that we are adhering to guidelines and working with our nephrologists to create algorithms for what to do with a positive screen so that people, are not also hesitant about when to send the urine again and when to refer to nephrology. Thank you.
Hi, this is Anna from Rainbow in Cleveland. I think this is a really important, I feel like we really struggle because we have a lot of different satellite clinics to on different sides of the city. And I think urine albumin, and then we had a lab change. So I feel like there's always issues with the urine. Like we can get the serum labs, but the urine has always been difficult. So I guess my question is, do you then have the family walk the urine over to the lab? Or is it someone like at the end, the MA takes all the urines over, or what's that next step for you?
So the patient care assistants will walk it over, unless there is like an hour where the PCAs can't walk it over anymore, and then the parents have to take it. So we have a small refrigerator to store the samples because they do have to be sent to the lab within an hour. Or I think 2 hours is the cutoff because we're not sending a culture. So we usually take care of it. Rarely do I have to, because at the time is too late, to have the family walk it over to the lab, which is in the same building as our clinic.
Hi, Jessica from Alabama. We also use the care gaps for a lot of our alerts, and I'm curious if a lot of your patients who you see for type 2 and other types of diabetes have primary care that are on the same Epic system. One time I had a pediatrician who ordered everything that was the care gap, routed the results to me and said, hey, it looked like this patient was due for it. And I was flabbergasted. It was amazing. And to me, that's the benefit of the care gaps and having primary care with access to that. I'm just curious if anybody anywhere has started to leverage with our primary care providers who are on the same network and platform.
That's a very important point because those patients, sometimes patients live too far. Or they have barriers to coming into diabetes clinic, and we all know those patients have to go to if not weight management, a nephrologist, a gastroenterologist, or hepatologist. So multiple appointments, and we haven't really started. We're working with Partners for Kids. Again, this accountable care organization is also very quality improvement focused, and they work heavily with primary care pediatricians. So this is one of the next steps that we're thinking to take. Currently, we're working with them on improving metformin prescribing by primary care peds for patients with type 2 diabetes that don't need insulin or they're newly diagnosed. But yes, I agree that this is a very important point, and we have to leverage the technology and the EMR that we have to partner with primary care. Great point. I mean, I haven't seen that happen. I hope I do.
Thank you so much for presenting this. This is really exciting. Liz from University of Wisconsin. Question about care gaps. Is that the same thing as the health maintenance functionality, and is it tied to the problem list? And then the follow-up question as I approach my Epic team, what do I ask for in that? Do you have to set up the protocols, or does it pull in automatically based on the diagnosis? What does that process look like?
So I do think it's a problem list based. So this is what what pulls it in is the problem list, and I wasn't involved in the build of this. I weighed in, but I could certainly have or put you in touch with my colleague who is actually our Epic liaison. My understanding is that it pulls up from the problem list. So, for example, when we have kids with type 2 diabetes and obesity, and they haven't been referred to the healthy weight center, or they have a high blood pressure, then all of these priorities are being listed under the care gaps. So I think whatever problems you put you can define what needs to be involved, what metrics need to be involved in the care gaps, and what defines those metrics. And this is how it works.
I'm really curious about your mail-in kits. How did you get that set up? And is there a vendor that you're using for them to mail it back to?
No, they are homemade. We, our admin team, we placed orders from our institution to, get the mailing supplies, and then our admin team helped put them together. You need them that much though. It's usually, probably 10% or so of the patients are coming back with a positive screen, and if you're able to get in touch with them and need that to happen. So they're not needed that much. They made maybe 100 of them, and we haven't even gone through half of them. But yes, they are homemade. So the instructions say, I can just It's very small, but I can tell you, like, it says that the family needs to refrigerate the sample, and then take it to the lab. And ideally, if they're collecting it in the morning, then they have to take it to the lab within 2 hours of collecting. No, they don't mail it back. They collect it and they walk it over to the lab. Yeah. No, mailing it back will require like, an ice pack and, it's kind of like transportation problems. All right, thank you.
So we will have CHLA with improving diabetes nephropathy screenings. Just gotta adjust the slides here.
Hi, everyone. I'm Laurel Gordon. I'm one of the current fellows at the Children's Hospital of Los Angeles, and similar topic. I'm going to be talking about how we tried to improve diabetic nephropathy screening in our clinical setting for both type 1 and type 2 diabetes. So overall, like we just talked about, we know that DKD is a very important thing to monitor for in both types of diabetes. There's been multiple studies showing that there's been a significant increase over the last 2 decades in the prevalence of this, both for type 1 and type 2 diabetes, over doubling in prevalence. And we know that albuminuria is the most gold standard measure for detecting this. However, there may be some upcoming new measurements such as cystatin C that haven't been very much validated, but could be going towards that in the future. And we know that there's multiple mechanisms by which glomerular damage occurs in both types of diabetes due to chronic hyperglycemia, such as mesangial expansion, tubular inflammation, and oxidative stress. And like we just talked about, we know that there's a significant increase in other comorbidities with the progression of diabetic kidney disease, with youth compared to adults having up to a 4 to 5 times increased risk of end-stage renal disease compared to adults with type 2 diabetes. So we want to just aim to intervene on this as early as we can. So as I'm sure all of us know, recommendations differ between type 1 and type 2 diabetes for when we start doing screening for diabetic nephropathy, because in type 2 diabetes, it's more of an insidious process, and there's thought to have been years of chronic inflammation and metabolic syndrome that could already be kind of contributing to this, whereas type 1, there's been little evidence to show that there's any kidney damage before 5 years after diagnosis. So it is just things as a reminder that we always recommend that it's collected as a first morning void, which we'll talk about might be a difficult barrier for a lot of patients. And then also it's recommended to confirm the presence of microalbuminuria with at least 2 out of 3 positive samples over a 6-month period. If patients are known to have confirmed this, then it's recommended to optimize treatment with glycemic control and optimize blood pressure for about 6 months. But then if the microalbuminuria continues, then you can consider additional interventions such as an ACE inhibitor, which some people might be comfortable initiating on their own, but some might prefer, to refer to other specialties like nephrology for further management of that. So we just started by creating a survey for our providers. We do have a pretty large amount, I think, compared to most places, of nurse practitioners and physicians. So we just kind of got whoever we were able to get to complete the initial survey. So we asked about both knowledge questions about current screening guidelines for type 1 and type 2 diabetes for diabetic nephropathy, and then also just more in terms of the timing of samples, when samples would need to be repeated, and overall criteria of number of samples for which they would meet criteria for diabetic nephropathy. So as you can see on the left, we surveyed a total of 20 providers. All of them correctly identified the type 2 screening guidelines. Only 70% correctly identified the type 1 diabetes screening guidelines. 40% selected the correct criteria for time frame and number of samples for you to meet criteria, while 70% selected the correct criteria for repeat sampling. And then we also just asked about relative practices in terms of when providers were starting an ACE inhibitor, when they were referring to nephrology, what they were considering a positive sample, and a lot of those responses varied widely. And then on the right, we did a just baseline chart review. We use Cerner, so unfortunately there's a lot of limitations in what we're able to do with our EMR for this. But we just randomly selected patients with either type of diabetes that recently had a urine sample obtained to check for microalbuminuria, and then what percentage of those had a repeat sample obtained within 6 months if they had an abnormal initial sample. So for type 1 diabetes, about 30% had an abnormal sample, and of those, only about a third had a repeat sample obtained within 6 months. For type 2, as you may expect, there was a greater percentage of patients who had an abnormal sample, and providers were better at, and patients were better at having a repeat sample obtained within 6 months. So it was about 2/3 of those patients compared to 1/3 for type 1 diabetes. So this is just the fishbone diagram emphasizing some of the common barriers. A lot of them, I'm sure you also have experienced, but I think in terms of things that, we might have a little bit more control over are our provider awareness on screening guidelines and remembering to order urine microalbumin, as well as just the educational aspect of talking to patients about why this is important, how to collect a first morning void, because patients might not understand that or know the significance of that. Again, like many of us share, we do obviously not every patient is able to come in, in the morning for an appointment. So that might limit our ability to collect a first morning void compared to a lot of the other screening labs for type 2 diabetes that can be done. Most can be done at any time. And then again, we also have high no-show rates, which prevents urine collection, and then just patients forgetting to remember to get their urine done at home, even if we do give them a urine cup to take home with them. So our specific aims were to improve from the knowledge aspect, to improve the percentage of providers who were able to select the correct timeframe for initiation of screening in type 1 diabetes, the timeframe for repeat sample collection, number of repeat samples needed for diagnosis within 3 months to 90% and 75% respectively. And then from the clinical aspect, to improve the percentage of patients with an elevated urine albumin to creatinine ratio who had a repeat sample obtained within 6 months, to 50% for type 1 diabetes and 80% for type 2 diabetes. So for our key drivers, we focused on the development of a standardized protocol and flow sheet for urine microalbumin to creatinine testing, because as we just showed, there were a lot of variations in kind of what providers were doing and what they were considering a positive sample, and just also in terms of timing of repeat samples, and then also just providing education on this to our department. Mainly, this is what we focused on for this, because it seems like this is something that, we can control and kind of get regular feedback on from our department in terms of things that might be missing or things that might be clarified to further help both them and patients, as hopefully this will also help them remember more frequently and screen more, which will create new points of conversation as well. So for our first cycle, which we completed, we developed a new diabetic kidney disease screening flow sheet for provider use, and we conducted an educational session with our department and one of our regular weekly meetings just to review the flow sheet, kind of get feedback from our providers on things that might need clarification or discussion points within the flow sheet to just make sure that everyone's on the same page and then clarify some of those things. And then 3 months after that, we reassessed knowledge with the same provider survey. For our second PDSA cycle, which is currently ongoing, we plan to place all these flow sheets in the clinic workroom so that physicians can easily refer to them when they're practicing. And then we currently already have all urine collection cups available in every room for providers to give to patients, but I don't think this is necessarily something that all providers remember to do. So working on having those available and then just placing them with an instruction sheet for patients on how to collect the urine sample, both in Spanish and in English, we have available for them to take home with them and bring to the lab. So I'm not going to get into the details of this, but this is just an overview of the flow sheet that we developed for providers to use. So it basically goes through both type 1 and type 2 diabetes, when to collect the sample, and then based on initial results, how to interpret that, when to repeat a sample, when to, for example, consider starting treatment with an ACE inhibitor or referring to nephrology. And we did this in conjunction with our nephrology colleagues as well to kind of help address some of those things that might be more unclear, and kind of some branch points for when they think they should definitely be referred to nephrology versus okay to manage from the endocrinologist perspective on an ACE inhibitor. So briefly just going over our post-cycle 1 results, we were able to meet our goal for improving the knowledge for our physicians on how often we screen for patients in type 1 diabetes and the screening guidelines to 100%. We were able to see some improvements in the other 2 questions, which were more focusing on time frame for collection of urine samples, and timing of obtaining a next repeat sample if the initial one is elevated, but not to our goals. So hopefully those are some things that we can continue to improve with regularly reviewing the flow sheet and seeing what feedback providers have after seeing this regularly within our clinic rooms as well. And that's all I have. Thank you.
We do have time for one question, if anyone has one.
I apologize for asking so many questions. I was curious about that next step with the ACE inhibitor. You had said that in your flow sheet, sometimes it would be okay for the endocrinologist to start and sometimes the nephrologist would want to start. Is it a simple thing that you can explain or would it require more?
I think so. When we talked to them, they seemed comfortable with us starting it as long as we had like baseline creatinine and GFR that were okay. But then they recommended for us, if we're starting it as endocrinologists, to make sure we're repeating that like within 2 to 3 months after starting. And then if there's I think like more than a 50% increase in the creatinine or a significant decrease in the GFR, that we then refer to them at that point.
That would make me scared.
All right, I get to be the last talk. And we're going to switch away from urine back to CGM, but staying in type 2. I think that's what the room says, so makes sense. All right. Cool. All right, so we're going to talk about CGM use and the importance of it. We all know that CGMs are great here. We've been part of the T2D exchange for about 5 years, and some of our first projects were really pushing that CGM in type 1, and we were so proud of ourselves. We're between 80 and 90% at least of people having CGMs. Now, when you start asking, are you really wearing it? That's a different topic for another day, but at least they have it. However, we really hadn't been paying much attention to our type 2 patients, partly because insurance has been a big issue. Our type 2 patients were like 70-80% Medicaid, and insurance doesn't cover CGMs unless people are on insulin. And even that has been actually something in the last couple of years, where now if a patient is on, depends on a little bit, but like at least on some amount of insulin, some insurances really want 2 types of insulin, at least on the MAR, in order to cover CGM. And so, but that has shifted in the last year or 2. And so we've realized, hey, we can push a little more for these type 2 patients to get on CGMs, but we need to focus on it. So we wanted to work on our barriers in our CGM use and overall increase. And I forgot to add this important detail here: percentage of CGM use for type 2 patients on insulin from 40 to 50%. This is not all type 2 patients. I would be like, hey, we're doing great if that was the case. But I know this is patients on insulin that can qualify based on insurance. And so we started with some initial and then some follow-up questionnaires that we administered to our patients. In one of our nurse practitioners' diabetes clinics, she's our nurse practitioner that sees, she has mostly diabetes clinics and sees quite a large number of our diabetes patients. And she's the one who actually had come to me because she noticed, hey, our type 2 patients are really missing out. So we said, well, let's try to figure out like just what's happening. We have, been working to collect our type 1 data on CGM use, but really we didn't have a lot of baseline data, not really, on our type 2 CGM use. And we're still sort of in some of that process. So we're like, how can we get some information and do something with it before we're fully data mapped, before we have the type 2 map. So let's just start with some questionnaires. So we looked at, for patients on insulin, what we would make note of their A1C, their CGM awareness, and then like their attitudes and different things about CGMs. And so this just shows like the first kind of two rounds of questionnaires. So here's our KDD. And our smart aim initially really was to like identify these barriers and try to increase the CGM use in our type 2 patients. We knew even before starting the questionnaires, just from our work with type 2, like obviously malfunctioning CGMs, access to care, health equity when discussing CGMs, awareness of CGMs, different locations. Like we have 2 different clinics we see patients at. One has diabetes educators, one does not. Things like that. So we knew those were things that were going to kind of influence what was going on. And then one important point that also popped up on our fishbone diagram was for our type 2 patients, if they're diagnosed and they don't need to start on multiple daily injections, they're just on Lantus or not on any insulin at all, which more and more, right? We're trying to follow those guidelines and do that for most of our type 2 patients. They don't come to our day 2 education class, which is where we talk about CGM, which I don't think is inappropriate, right? Like they probably don't qualify for CGM. They don't need that day 2 class where we talk a lot about carb counting and all that stuff that goes with multiple daily injections, but they miss out and they don't ever really hear about CGM. And so that became really obvious when we got our first round of survey results back, where the CGM knowledge there on the right side of the screen is for patients with type 2, and almost 40% said they hadn't heard of CGM, which was wild to me. I was like, oh, cool, that's our problem. I was wrong. That wasn't the whole problem, but it was a big part of it. And I think a huge part of that is because we just didn't have it as part of their curriculum, which again isn't totally inappropriate, but we have to figure out how to make up that gap once they are on insulin. How can we bridge that? All right. And you can see in this nurse practitioner's clinic who was really feeling like there was a huge gap in CGM use. She was right in the sense of that it was the type 2 patients that were really not on CGM. Her type 1 patients were doing great though. Because I was like, wait, why are her patients doing so much worse? Why our T1D CGM use is pretty good. And we were right. It just was the type 2. It's dragging it down. So asking about like the reasons why people aren't on CGM was very similar across the board. I'll go into a little more detail, but uncomfortable and it comes off easily, either no interest or people put it on and then they like say it's off by 100 points. I don't want it. And so then they don't want to go back once they have a couple, a CGM rare where they're like, no, it's way different than my finger stick that I've been, told to trust above all else it's not going to work. Having lots of like issues, just sensor failures, or insurance. No insurance or insurance wouldn't cover the cost. And that was definitely a huge issue. And so then breaking it down based on type of diabetes, other being like steroid induced or transplant induced, a couple MODI. But you can see for the type 1, the failure and accuracy and malfunction is much higher because they're the ones that are actually wearing it. So then they can have complaints of malfunction. Whereas type 2, it's access and then burnout. But I think really in the type 2, that's actually truly more hesitancy and no interest. They're just not wanting to put it on. They haven't heard about it early on in their education. It hasn't been brought up enough. They don't want to. And so we did like a second round of questionnaires with the same group of people who had been asked the first time. And of our type 1, about 80% report using the CGM most of the time, but really like much less of our type 2 patients reported the same. And really most of the patients that were having trouble getting it were still having trouble getting it the second time. Like if after that first questionnaire, it sparked a conversation and we went ahead and prescribed it. So far in our initial stuff, like the chances of them actually getting the CGM were still really low. Or they were still having issues of it not working in some way. And so the barriers reported were the same, but the percentages are kind of low on this because a lot of our type 2 patients just still weren't on the CGM. The prescription was sent, but it never got to them. And so obviously the awareness and access of CGMs varies hugely. And so working on increasing that, we now have a handout in our clinic. I don't know if patients really look at these, but at least it's something that as providers we can point to a little bit when we're talking about it. And there's some pictures of that we put together ourselves of the CGM on the patient and things like that to help, and what it looks like on the phone and what the device looks like and all that stuff. We've realized that our prescribing, if it has to go through a DME company, we may have been doing that wrong. And that was brought up by our pharmacy tech who helps us with the CGM that we discovered in the last couple weeks. So that maybe will improve for some of the times where it's like, well, we sent the prescription. Why are you still saying that your pharmacy didn't have it? And then, so we need to circle back and keep working on that. And really start thinking about when we are doing education for patients, when we're starting them on insulin, if they're type 2, that we realize we have to escalate care and go to insulin, incorporating CGM in that education time. And so that's going to be some of our next steps. And I did it in 9 minutes.
Time for some questions, if anyone has any.
Hi, I'm Elizabeth from Johns Hopkins. Do you have access to any samples that you could give your type 2 patients?
Yes, we do now. And that's been something, honestly, probably over the summer, we've gotten much better about finding all the ways to get samples. And so that is something, and we have given those out. It has not, and actually this NP, that was one of the things that she did do. It didn't increase the number of people who we were able to get the insurance though. That still gummed us up a lot. Yeah, if people don't know about the Dexcom hospital discharge thing, David Tooley, he might kill me, but he can hook you up and it's amazing. And you can get a whole lot of Dexcoms. And receivers, which is another big issue because people break receivers and they are $400, I think. It's ridiculous. And so patients that oh no, I've lost it or I've smashed it. Anyways, now we have receivers we can give out. That's what. Yes, yes. Is that only pediatric? We're pediatric. Okay, I apologize. Maybe it's only pediatric. I don't know. Okay. No, yes. So it's 3 sensors and a receiver, and you can get lots of extra sensors. It's magic.
Thank you so much for this presentation. Amy Putker, Cincinnati Children's. Curious, and I may have missed this in your presentation when you were assessing barriers. So in our clinic, we're pretty lucky in Ohio. Most of the surrounding state Medicaids will cover CGM regardless of diagnosis and regardless of therapy. So we're able to get coverage for our type 2 patients. But to be honest, I don't think it's really improved their utilization. And one of the, I think, general themes that come up, at least in our type 2 diabetes pediatric patients, is I really feel like diabetes stigma. They do not want people to see it on their body. I think, I think there's just a lot of factors. So I didn't see that in your barrier assessment. Was that part of it?
It was. I mean,
Okay.
the hesitancy and the not wanting to, and I should have gone into that more because I'm not sure we're asking the right question in our survey to truly get at that. But that's when I talk to these patients about it, that's definitely what I'm hearing. And it's a good point. And maybe as we kind of rework this, we do have a question about, are you wearing your CGM? And if not, why? And we have a couple things you can push, and we're working on redoing our like intake form and making sure that, and probably making that a hard stop. I heard somebody else did that, and I was like, that's a really good idea. But something about like, is it that you don't want to be seen in public or something, I think would be a really good option on the drop down menu, because I agree, I think that is a big part of it. And I think the videos people are putting out and stuff, we keep talking about making them, but maybe I should just steal from somebody else. Not right now, because our insurances suck in Tennessee.
With these patients, and sometimes do a trial or do a sample and let's get 14 days of data, you know, even if they're not going to wear it long term, because I feel like they can still learn from it. Occasionally I can get it covered without insulin, but my other question was going to be, are you doing primarily Dexcom versus Libre? Yeah. Yeah. I have a lot of issues in this population with adhesive. Like I really find that different ethnicities, the skin, it really doesn't stick, and the obesity aspect, and even more so than the type 1 population, I'm just continually troubleshooting how can I get it to stay on these patients, and I wish it was addressed more from the CGMs.
They have they have standardized their education around like, you know, making those sensors stick for longer. And then they have also sample kits that I don't know how they occur, you know, those supplies, but they have sample kits that they give to patients, including skin tack and different types of like overlay patches.
This population, I find a lot of those extra adhesives are covered by insurance.
Right.
So then I'm not being like, you can get the cheapest on Amazon.
Yes, they are strictly out of pocket for everybody. I agree. So the only reason why I asked this question is because right now, you know, we're trying to avoid insulin if possible, and you know, we have other things like, you know, besides we used to prescribe, you know, insulin to everybody. But now that, you know, when you see like an 8% or 9%, you're like, I can do this with metformin and a GLP-1. And those patients still have high blood sugars that require, and they may get worse very fast, as we know. And so being on CGM is, you know, we're lucky. I'm also from Ohio, and we're very lucky to, you know, we have healthy, normal children on CGMs in Ohio. You know, I think this is a very important consideration.
And I thought your point about just the 14 days of data is helpful and interesting. And I'm curious if anybody has had experience with using, obviously they are not FDA approved and under 18, but some of the over-the-counter options. We've got some families that the burden of dealing with DME is worse than the over-the-counter cost. And I'm curious if anybody has structured either how to do a 2-week, just get some information and have some good education in families in patients who maybe don't have insurance coverage or don't meet criteria for state. Because I think there's a good, it's one thing to say eating a donut makes your sugar go up, and it's another to see that. And I think those of us who give samples to our medical learners, they see that, and I'd love to do that with the patients too.
Public insurance, or even if you have a public primary, even if you have Medicaid secondary, you can get a trial, like you can get a Libre trial for free. So you can just have, like, just go to the Libre, have patients go to the Libre website. Yeah. I think you actually have to have public insurance. I think it's not a program that's available if you have private. Maybe it's the opposite. Sorry. I think it's private. Yeah. Unless it's a secondary and they have private primary. That's what it is. Because then if you just have to verify that you have some kind of private insurance, but then you can at least get a sample, which I know doesn't affect a majority of like this population. So it's still a challenge, but it is a situation where, and I appreciate too, in the state of Wisconsin, we also have like CGM only covered for type 2 patients on insulin. But we are finding more and more that like we still want to recommend it. We still want people to know that it's a great option for them and point out like this is unfortunate and we need better advocacy efforts. And for some people, paying out of pocket for a Libre makes sense for them in their grand scheme of things. Similar to your point of like the DME burden is too great, but I'll just send it to Costco and you could just go buy it.
I don't know how similar other states, but we recently found out in Washington for Seattle, if it's not covered by insurance, each Libre Plus was only $30. I'm like, wow, that's impressive. Yeah, at 15 now. And so we said just maybe buy one or two, right? And then wear it right before the clinic visit or, have fun for 15 days. But it was so much cheaper than I had imagined.
I kind of almost wonder if the intermittent access actually has more behavior change, because when you get a new step number, you walk your 10,000 steps, you wear it all year and you're back to the baseline. But if you do it intermittently, for type 2, yeah, what's not, not, I mean, I think they've shown for MDI, but like, really type 2 is just on business.
Yeah. Just a comment as we're having this conversation. So I actually have a hospital discharge contact with Abbott that I can order similarly trials like I do for Dexcom, and that has been tremendously helpful. And after months, if not maybe a year of leaning into my rep, I actually get readers now for Libre 3 because they kept asking me why is Dexcom being prescribed so much more heavily. And I'm like, it's easy. They made it easy for us. So, and that's really only been a change in the last 4 months. So if you've not been in contact with your reps recently, feel free to, I think her name's Heidi Woods. I'm happy to share out. We threw David's name out there. Well, may as well throw Heidi's out there as well. But I have found that very, very helpful. And I do think that as a company, they seem to be wanting to be a little bit more competitive. So we'll throw that out there.
Right?
Yeah.
And so maybe but if we have to follow after that though, or parents are gonna have to big barrier for the
Not if it's connecting to the pump, but if they're using it as a standalone system,